Hello, everybody, and welcome to the Research Roundtable, the I-CBT live stream where we pick and choose some of the hottest topics in the OCD literature and highlight some really cool work going on in the field. As always, my name is Kyle King. I'm a rising junior at Yale University with a focus in OCD, and that's not just because I think it's a really fascinating disorder, although I do think it's a fascinating disorder. It's also because I have OCD myself, so learning more about its treatment and its neurobiology is something that is really relevant to me. As always, I'm joined by my co-host, Jon Abramowitz. Jon, if you want to introduce yourself.
Sure. I am Jon Abramowitz. I am a professor at the University of North Carolina at Chapel Hill and a clinical psychologist. And I am also fascinated by OCD and happy to be here once again.
Yeah, and as people trickle in, please feel free. We love getting to know you guys and meet you guys. So let us know where you're tuning in from. And also let us know if you went to the OCD conference. The IOCDS conference was last weekend in Denver. I got to meet Jon for the first time. I've seen him on screen for many hours. I wasn't entirely sure he had a third dimension. He does. Well, he has 4 dimensions if you include his personality. It's just but yeah, it was a super fun time. I also got to meet a lot of our former panelists, which was super cool. So feel free to type in the chat, let us know where you're tuning in from, and how everything's going. And we also have 2 new panelists on the show today. But before I get to introducing them, I have to do some disclaimer stuff. So I'll start there. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDS online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. Also, I already kind of mentioned that you can use the chat function whenever you'd like, and we do encourage you to shoot us questions. We'll try to get to whatever questions you guys have. But just a word about the chat function. This is a live stream, so everything you put in that chat, like we can't really filter or censor, and it's gonna live on the internet. The stream is for a while afterwards. So be cautious, be mindful of what you put in the chat, and please be respectful of everyone. Goes without saying. All right. Now let's jump into introducing our panelists. I think I'm going to start with Kelvin. For anyone who's listening, Kelvin is in Australia right now. It's 2 a.m. I think it's our second Australian panelist. So Kelvin, thank you for being a champ and coming onto the stream.
Yeah, no worries. Glad
to
be here.
It's winter time down there, right?
Sorry?
It's winter down there.
It's winter. Everything's
upside down.
Yeah. And the toilet's flushed the other way.
Yeah, that's right.
So Dr. Kelvin Wong is an assistant professor at La Trobe University and early career researcher. He's an experimental clinical psychologist with a focus on understanding the underlying causal and maintaining factors of obsessive compulsive and related disorders. He has published numerous works on the role of cognitive factors in OCD, such as imagery perspective, fear of self, and other beliefs and dysfunctional reasoning processes. Kelvin, I normally would say, like, how you doing? But I'm feeling a little spicy today. So what's your favorite ice cream flavor?
Oh, my God. That's I really like taro. I think it's something about the color. It's nice and purple.
I've never heard of that ice cream flavor.
Never? Oh, you're missing out. I don't know. I think people in your chat might be getting upset at you for not knowing. But
you said it's taro?
Yeah, taro.
Jon, you know it?
I have had the frozen yogurt version of it, but not the ice cream version of it. So it's
okay. So you're more educated than I am. And now on to our second panelist, Dr. Fred Aardema. Fred Aardema is a clinical psychologist and associate professor at the Department of Psychiatry of the University of Montreal. He completed his doctoral studies in 2005 at the University of Amsterdam in the Netherlands. He was originally trained and supervised by Professor Paul Emmelkamp. Is that how you pronounce it?
Correct.
All right, cool. The first to investigate cognitive interventions in comparison with behavioral interventions in the treatment of OCD. In 2009, Fred joined the Montreal Mental Health University Institute Research Center and the University of Montreal in Canada, where his research aims to improve our understanding of OCD and its treatment. As one of the founders of inference-based cognitive behavioral therapy, Fred is particularly focused on the further validation of this treatment approach to provide patients with OCD with effective alternative evidence-based cognitive behavioral treatment options. He is currently leading a large-scale non-inferiority trial funded by the Canadian Institute of Health Research comparing I-CBT with exposure in vivo and response prevention. Fred, what's your favorite pizza topping?
Good question. Good question. I would say prosciutto.
Oh, well, fancy.
Yeah.
I was thinking more like pepperoni.
No, I don't like pepperoni too much. Prosciutto.
I like
some arugula on the top. Yeah.
I have one anecdote before we kind of get down to business. So when I was in school, my last name starts with AB. So when I was in school, I was always like front and center, when the teacher would kind of line us up alphabetically. And I always had to have my homework done, first, because the teacher would always call on me first and all that stuff. There are very few people who can beat AB. But Fred, I've read your work for a long time now. You are one of the few people that would be ahead of me in alphabetically if we were in school together.
Oh, yeah.
What it's worth.
I was invariably I was picked first. Right?
Yeah.
For anything, any exam, always had to go first, which was beneficial in a way because you know what's coming ahead of time, right? So
yeah, that's true.
Well, yeah,
get it over with.
Right.
And if you're like me, you just like set the bar low.
Yeah.
And then,
Exactly. Although being the first in the phone book wasn't always pleasant, So, but,
yeah. So today we're going to be talking about inference-based CBT. And I gotta say, if you're reading about this in the literature, it is impossible to escape Fred's name. But before we get into I-CBT, I want to take a big step back, just because I'm not super familiar with everything. And I want to know what we're comparing it to just from the get-go. So Jon, if you could give us a brief overview of what is CBT, so we know what like I-CBT is really going to be up against, or what it's a spin on.
Yeah, well, and I think we can think of, and Fred and Kelvin will tell me if I'm wrong, but I think we can think of I-CBT as, well, it's obviously it's in the name, right? So it's CBT is such a broad umbrella of different techniques. There are different techniques. So, typically we think of exposure and response prevention as being the first line cognitive behavioral psychological treatment for OCD. But exposure and response prevention are two techniques that fall under the big CBT umbrella. And so we're going to hear about some different techniques. And I wouldn't think of them as being against one another, because as clinicians, I think we want to take what's out there in the research and we want to combine what's good and think about, maybe how we can use these things together and benefit the most we can from different techniques. But I'm going to leave that to Kelvin and Fred.
Yeah, no, I mean, for sure. I think clinically, a lot of things can be combined, right? Theoretically, there's sometimes differences, right? But clinically, it's possible to combine a lot of these different treatments that fall under the same umbrella, like you say, as cognitive behavioral therapy. So I-CBT is a cognitive behavioral therapy, but it's sort of like different from let's say standard CBT or ERP, exposure in vivo and response prevention. And the difference lies primarily in its focus on obsessions and how I-CBT conceptualizes obsessions, which is I-CBT conceptualizes obsessions as an inference of doubt, a doubt, which implies it's sort of a conclusion about something that could be or something that might be. For example,
okay. There's a lot going on.
Yeah.
I want to make sure I get everything straight first.
Right.
So,
go ahead.
I-CBT is a type of CBT, and the primary difference between just like I-CBT and standard CBT, as you called it, is like a theoretical difference.
There are theoretical differences for sure. Yeah.
And the primary theoretical difference is in how you conceive of obsessions in OCD.
Right.
Okay, so what's that difference?
Well, let me give an example. The way I-CBT conceptualizes obsessions is as an inference of doubt. So it's a conclusion. It's about something that could be or might be. Let's say, for example, when I have the thought or obsession that my hands may be contaminated. It's a thought, right? It's an inference and it's a doubt. Or that maybe I left the door unlocked. It's also an inference and it's a doubt. Or the thought that maybe I'm a dangerous person capable of doing terrible things. It's an inference and it's a doubt.
Why do you call it an inference exactly?
Good question. Because when we ask people with OCD, why do you think that your hands may be contaminated? Why do you think that you may have left the door unlocked? They come up with reasons as to why they think they may have left the door unlocked. So they actually arrive at it through reasoning. For example, they may say, well, there may be dust in the lock when I try to turn the key and therefore it's unlocked. Or it may be unlocked. Or maybe I did not pay enough attention. Or I heard of a friend who once locked his garage, or thought he locked his garage, and then found out that it was unlocked. So it's possible that I now forgot to, or that I did not properly lock the front door. So there are reasons which we call a narrative. So that's why we call it an inference. That's originally how the treatment was developed, by simply asking people, why do you think that you may be dangerous? Why do you think that your hands may be contaminated? And that's different from other cognitive models.
How so? And Jon and Kelvin, feel free to weigh in.
Keep going, guys.
All right. You want to do it, Kelvin? You want to?
Yeah, how is that different? That kind of focusing on the inference.
So I think in a lot of your traditional sort of CBT approaches, like your traditional like cognitive appraisal model, where there's a focus on beliefs about responsibility, about perfectionism, those kinds of things. These models treat the sort of the obsession as the intrusion as something relatively, not so much the content of which is so important, right? So the focus of it is not the intrusion or the obsession itself, right? It doesn't really,
on the behavior and countering
the focus is on how the person interprets the thought or the
attached to it. Yeah, exactly.
Right. So it's the meaning that they attach to it. That's the problem. That's what these other sort of the more traditional models sort of focus on. Whereas in the inference-based approach, actually what the inference-based approach suggests is that how the person arrives at that initial intrusion or obsessional doubt in that case is as a result of this sort of more faulty sort of reasoning kind of process. The person already arrives at that starting point, which a lot of other models assume as, everyone has this going on for them. Everyone experiences these intrusions, but actually the inference-based approach suggests, hang on, actually how the person reasons about it leads them to arrive at a sort of already, I wouldn't necessarily, maybe Fred jump in here if it's probably more pathological or a sort of dysfunctional kind of intrusion, or in this case, an inference about
doubt. Yeah, inference of doubt. I mean, we in I-CBT, we don't really use the term intrusion because the thought does not really intrude from the perspective. There are reasons behind it. It doesn't come out of nowhere, and that's sort of the claim. That's sort of the claim of let's say the appraisal-based model. I know you were mentioning behavior. I think I-CBT is not so much theoretically in conflict necessarily with ERP. As much as it may be with appraisal-based models of OCD. Because in appraisal-based models of OCD, the intrusion occurs randomly, which develops, sort of goes through a caterpillar stage, which develops into an obsession or escalates into obsession depending on the significance the person attached to that thought, how the person appraises it. What I-CBT would claim is that there are reasons behind this. They do not occur randomly. They do not come out of nowhere. So they are actually already inherently emotionally charged when they occur in the case of OCD. And they also contain evaluative dimensions, which means They're not sort of meaningless thoughts. There's meaning in these thoughts right from the start. It's an entirely different concept than the idea of intrusive cognitions, right? So there's a story behind them. There's a narrative behind them. And this narrative is exactly what we address in therapy during I-CBT.
So does I-CBT... Oh, you go, John.
No, go ahead, Carl.
No, I was going to ask you a question too, so go.
So my, right. So in reading the literature, that idea that, where the thoughts come from is not I guess we're not saying intrusive thoughts, where obsessional thoughts come from, is not random. That certainly speaks to me. Like new parents tend to have thoughts about their baby and all that kind of stuff.
Yeah.
But there's plenty of evidence that, everyone does have the same kinds of thoughts that people with OCD have. The old Rackman papers, and even new parents, with and without OCD. I always thought, and I guess in reading the literature to kind of prepare for our talk today, I can kind of see it both ways. Like, does it have to be either or? Could it be that we got both processes going on at the same time? Or for some people or some types of obsessions, it's one or the other?
Possible, yeah. I think it's there's no denying that, as you say, that in terms of content, we all experience these thoughts, right? But I think what you have to differentiate in the case of OCD, that they arise differently than normal intrusions do. When you look at the process by which obsessions arise, in terms of the narrative and the process that is part of it, it's a different thing than normal does.
How so?
If you look at these narratives, and that's what a lot of our research has focused on, what is the particular process that leads to obsessional doubts versus normal doubts? And when we look at that process, one of the central elements that seems to be part of these obsessional doubts is that there is never any direct evidence for the doubt to support, or for the doubt to be supported. Never any direct evidence in the here and now related to the senses. So let me stick with that door example. When the person thinks they may have left the door unlocked, there's nothing in the here and now that tells them that the door is actually unlocked. They come up with all sorts of hypothetical possibilities. They generate doubt continuously. Maybe dust in the lock. It's possible. Maybe I didn't pay enough attention. But nothing in the here and now. Contrast that with a normal doubt, a justified doubt, where, for example, I turn a key in a lock and I hear a crack. And I think, maybe I did not lock the door properly, or maybe it's not properly locked. That's a justifiable and reasonable doubt, correct? So in that moment, you have a reasonable doubt. I may not be sure whether it's or not, but at least it's reasonable. There's something in the senses to justify it. So this is sort of like a central process or a central part of the model where we say, okay, obsessional doubts are generated differently than normal doubts. And that is what we address in treatment. Now, in a way you can say, since there's no direct evidence, this entire narrative or obsessional doubts are constructed entirely on an imaginary basis, meaning they're constructed not by the faculty of perception, but they are constructed by the faculty of the imagination. And that has implications, because if a doubt or an obsessional doubt is generated solely by the faculty of the imagination, then it's 100% irrelevant to the here and now and can be dismissed on that basis. And that is what we try to show clients with OCD during treatment.
Does the model see OCD as like black and white, like either you have it or you don't? And if not, how does it account for OCD kind of occurring on a continuum with normality?
Well, I think there are gradations of the extent to which we apply, to the extent to which we arrive at inferences of doubt that are obsessional, right? To what extent do we rely or do not rely on sense information can vary. But I mean, an obsession is an obsession. It's either an obsession or it's not an obsession. So there's a discontinuity there. But in terms of severity, yeah, for sure, there's a continuum there.
Yeah. And just to quickly jump in back to your previous comment, John, about how these other papers have shown that sort of everyone experiences intrusions. I do wonder, and whether or not results might have been slightly different had they, like Fred's explaining right now, also asked the patients, like, well, why do you think, to provide sort of those justifications for those sort of obsessional doubts. Because I could imagine that so through some of those interviewing techniques, they sort of assess for that final doubt, like, oh, I might be a murderer, or I might, my hands might be contaminated. But had they asked for that justification, maybe it would have revealed the sort of more richer narrative, which in the inference-based approach would consider as part of the obsession, really, and would have revealed actually that they would have been quite qualitatively different. So I do wonder that, but I don't.
That's actually research that we have done, right? I mean, we have looked at the context of in which these obsessions tend to occur, but also we had actually a recent study done by a student of mine, Dr. Jon Abramowitz. He just graduated. So and he was looking at narratives. And we had obsessional narratives. We had like 100 of them collected over the years, obsessional narratives, and we had different groups of clinicians look at it. Those from an appraisal-based model, those from an inference-based model, and a naive group of students. And we asked them to rate on a scale from a 0 to 100 whether there was any evidence in the senses, in the here and now, for these obsessions. The score was 5 on a 100-point scale. So that's low. That's you can't get much lower than that in terms of like the possible distribution. So it really seems to be a characteristic of these narratives, the justification behind obsessional doubts. People with OCD seem to arrive differently at it. Now, that's not to say that people with OCD, I don't know how to reason. It's not a matter of intelligence, because actually in most situations, people with OCD reason entirely normal. Right? It's only specific to the obsessional situation. So, for example, which goes back to the selectivity of the obsessional doubt, which is actually something we harness in therapy. We sort of like tell the person about you reason differently in that situation than in the OCD situation. So it sort of highlights the different type of reasoning that you apply. If you cross the street, you look left, right, and left. You don't ask yourself like, and you did not see a car. You don't tell yourself, well, maybe there's a car, or a car maybe come by, maybe there's light shining in my eyes and I did not see correctly, so I cannot cross the street. These doubts do not come up, well, unless they're obsessional, but they don't come up, right? The person doesn't bypass the senses to the same extent. So they cross the street, they trust themselves. So it's a lot about trusting the senses, or in the case of OCD, distrusting the self and the senses, right? This goes back to the feared self-perceptions that we can talk about a little bit more. But in those cases, the person trusts themselves, crosses the street. So in almost every other aspect of life that's not obsessional, there's no problem with that reasoning. They just apply it to the obsessional situation.
How do we, all right, so my understanding, kind of backing up, is that really the big difference between the inference-based model and the kind of traditional appraisal model, the kind of Beck-Ellis appraisal model, is that in the appraisal model, the obsessions, the unwanted thoughts come first. That's the A, and then the B is the interpretation. Okay, and then in the inference-based, the person already has a story, this inference, this doubt, whatever, and that's what kind of leads to the unwanted thought.
Exactly. Yeah, it's like the appraisal model is a mediational model. The inference-based approach is a constructionist model. Both cognitive models, but different. Also, the inference-based approach, another way to look at the difference is it goes more upstream, right? Before even the obsession occurs, whereas the appraisal is more downstream, right?
Yeah.
But they're all cognitive models.
They're all cognitive models.
Yeah.
So, like speaking from like my own experience, the whole time that I was suffering from OCD, I knew that my obsessions were like, the logic was faulty. Like I knew it was crazy what I was thinking. So how does the model kind of account for the patient like understanding that their rationale is completely wrong?
Right. I mean, they're ego dystonic often, right? Not always, but often that's what we call ego dystonicity. The sort of like, you sort of realize that sort of like irrational, it doesn't make any sense. But often the implications and why they are irrational is not completely understood. Because when you ask a person with OCD, even if there's a high level of ego dystonicity, I said, I know it makes no sense, it's irrational. We ask them, okay, it's irrational, but I mean, why do you think it could be true? Why do you think it might be true? And usually, invariably, the person goes back to, well, yeah, I don't make sense, but it's a possibility it could be true. And there are reasons for me to think that it could possibly be true. So it's OCD only needs a very margin of possibility to survive. 0.0001% is enough for OCD to survive. It can hook into that, right? What I-CBT tries to do and tries to say, even at 0.001% does not really matter, because it's constructed entirely on an imaginary basis, which renders the obsession irrelevant. That's a central process. That's almost what all the exercises of the treatment are focused on. And it takes a while before a person fully realizes the implications of that, how it's constructed. But when they do, it can make the OCD collapse like a house of cards.
Yeah, I guess when I hear that, it sounds like it sounds correct. Like I knew my thoughts were irrational, and I knew that like they were constructed entirely by my imagination. But if my therapist had just told me that, it wouldn't have stopped me from compulsing. So like pointing it out, it doesn't feel like enough. So what exactly is the active ingredient here?
Well, I mean, yeah, pointing it out. I mean, there's a cognitive shift that has to occur, and a full realization that the doubt is constructed imaginary, including its implications. You know, and that's not automatic by just telling the person like is constructed in a way that does not justify the obsession. So we have exercises of doing that. I'm building up to that and applying that and applying the implications of that. So one of the first exercises we start with is being able to tell the difference between normal and abnormal obsessional doubts. Being able to tell the difference between justified uncertainty and unjustified doubt or uncertainty.
How do you help people do that? Because I have patients that, I mean, they struggle with exactly that. How do I know that it's just an unwanted sexual thought about a child? And what I tend to use a more exposure and response prevention. And we talk about, well, you can't really know for sure. We have to, because, they've been trying to do rituals in their head. Let me figure this out. Logic doesn't seem to work for these folks. I'm curious about how you guys are able to convince them
that the logic works.
That what's what. I would use that in a
I mean, that's like I said, the obsession is constructed not on the basis of sense information. So that's a central difference. The OCD tries to bypass that. It creates all kinds of hypothetical possibilities that make it seem like the obsession is relevant to reality, often by going beyond reality, by dismissing reality through irrelevant associations. So we have the person identify their obsessional narrative, write it out, and we identify all these tricks and cheats of the obsessional, of the OCD that can make the impossible seem probable. Or I shouldn't even say impossible. These things are possible. It's not like obsessions are not possible. The problem is that it's not relevant. The problem is that not relevant. And from that perspective, it's also not a matter of tolerating uncertainty either.
It's not a matter of tolerating uncertainty.
No, not in I-CBT.
I mean, how do you convince someone
with there is certainty in the senses. There's certainty in the senses before the obsession starts. There's certainty in what is there.
I'm not quite sure how you convince someone with OCD that that's the case.
Well, I mean, that's what our trials show, right? They get better, or a lot of them get better. So you can convince them, and it's not a matter of convincing. It's a true realization of that the obsession is generated or is not relevant to the here and now, not relevant to reality. And we have different techniques to do that. Like I said, the distinction between normal and obsessional doubt, identifying narrative, identifying the reasoning devices of the OCD that make the possible seem relevant, even though it's not relevant to the here and now. We highlight the selectivity of the obsessional doubt. We have different exercises that include being able to identify the thoughts that take you beyond reality. that take you into the OCD bubble, that take you into compulsing and into rumination, into the imagination. We have exercises that include reality sensing, which is an interesting exercise because if there's any sort of like, which reality sensing is what we conceptualize as actually using the senses normally in obsessional situations, and not putting in additional effort. In that sense, a little bit similar maybe to response prevention in ERP, right? Or neutralization in the clinical model.
Can you explain that in different terms? I didn't quite understand it.
What part did you not understand?
Like the reality sensing exercise, is it?
Yeah,
like,
so we ask people to go into obsessional situations and to not put in additional effort. Now, that's not an exposure exercise because the purpose, I mean, it's similar. There's an exposure element involved, you could argue, but the purpose is not to provoke anxiety. The purpose is also not to provoke uncertainty. The purpose is to act with the same certainty based on the senses that we all experience.
So the person learns what? Like, what's the goal of that exercise? What are they getting out of it?
To do things normally without compulsions, to act as they already do in non-obsessional situations, and to apply the self-trust that they experience in non-obsessional situations, and the trust in the senses that they have in non-obsessional situations, to also use that in obsessional situations.
So all right, so they're learning trust in the senses. How do you know when someone has learned to trust their senses?
Well, I mean, there are different steps in the treatment, right? This is one of the last exercises. Once all the cognitive work has been done, of the previous steps I mentioned in terms of realizing that obsessional doubts are indeed irrelevant to the here and now, then the anxiety should have gone down to the extent that these exercises can be done without too much anxiety to start with.
So it sounds a lot like exposure from an inhibitory learning or an ACT perspective. It's not about habituation. It's more about learning, hey, I can move forward. I can trust my senses, and I can move forward and do these, do the things that are
sure. For sure, it will reinforce the idea that maybe there is no danger. Maybe I don't have to worry about things. Maybe I don't have to tolerate uncertainty. Yeah, exactly. Yeah. Do you have something to add there, Kelvin?
No, it's funny because I think Fred and I definitely did have a chat about this and talking about like the inhibitory learning approach and sort of like the differences there. And I think, like you mentioned, Jon, there's like some sort of like learning element in this part of the therapy. I mean, Fred is definitely more of the therapy side of things as well as the theoretical. But I do think that there is a little bit of that in like learning, like the person is learning to, trust what it is that they're seeing, as opposed to which is in conflict to what they sort of had believed before, which was, I can't trust what it is in my environment. Or
it would seem like there would have to be the person learning trust. In other words, they're learning how to, you're not going to like it, but learning how to live with uncertainty. They're trust. I mean, what is trust? Trust means I don't know for sure, but I'm gonna have faith. I'm gonna move forward. I'm gonna accept this, which it sounds like, which isn't very different from, like what we're trying to do with more traditional types of treatments. It sounds like there's more of an emphasis on kind of some of these cognitive elements on challenging the story up front. I don't know, or do I have that wrong?
No, it's the opposite, because we're actually saying you can have certainty, same as you have certainty and I have certainty and we all have certainty that we are not dangerous, that we are not pedophiles.
Do we have certainty in that? Like
I do.
101% ironclad that you're never going to molest a kid.
Of course.
You do? Because I can't say, and this is on the internet.
Yeah, this is on the internet, Jon. You better watch yourself.
We've gone here before. Like, I don't have a crystal ball,
No, I mean, that's not how you reason, John. If you would really have no certainty, you would have OCD. You can say that maybe from a sort of like theoretical, sort of detached sort of perspective. I don't have certainty, but you don't live your life like that.
But we do. So I'm gonna get in. I have to go to the campus. I'm in my house. I got to go to campus later on. I'm gonna get in my car, and I feel like I'm gonna get there safely and arrive and get home for dinner and all that kind of stuff. But I don't have a guarantee of that. That's more like.
I think that's really where, I mean, look.
Yeah.
I-CBT does not clash with ERP, but the idea of intolerance of uncertainty is a cognitive theory. It's actually not even cognitive theory. It's more like a trait-like construct that blames OCD symptoms on a person not being able to tolerate uncertainty. There's no evidence for that. There's no evidence for that. It's not a specific. It's a process that's relevant to anxiety disorders. There's no evidence that it's specific to OCD. So I think ERP can be combined, if you want to, with I-CBT, but to consider an intolerance to uncertainty as something, as a causal factor in OCD, or even relevant to it, I think there's no evidence for that empirically.
You're saying there's no evidence that intolerance to uncertainty is relevant to OCD?
No, it's relevant to OCD, but it's not specific to it, and there's no evidence for it being a causal factor.
No, I mean it's right. It's a non-specific, absolutely cognitive factor that's present in OCD, generalized anxiety. Really, I mean, most problems with.
Right, and because of that, I don't think it should be play such a central element in any treatment. ERP is fine. I mean, that's just like experiential learning in some sense, as Kelvin has pointed out in the past. But intolerance of uncertainty. But I-CBT is about saying you can have certainty in the same way that you have certainty. Like, do you think you forgot to lock the door this morning? Usually we don't. The thought doesn't come up. Because we don't consider it relevant. Yes, it may be possible in the abstract. It may be possible in the abstract.
But you know what? That there are people with and without OCD who check their door. I mean, or who.
But I think it's more like you could theoretically have uncertainty, but like day to day, like what Fred is saying is like functionally you're certain about it. Like you're not thinking about it. Yes, abstractly there could be uncertainty.
Yeah, but that's the point of I-CBT, that people with OCD bring abstract possibilities as evidence for making the doubt relevant.
Yeah.
Right? That's the whole point. So right?
Yeah.
Okay.
So I want to bring the discussion kind of out of the theory for a moment. So Fred and Kelvin, if I'm a patient with OCD and I'm stepping into a therapy situation with someone who practices I-CBT, what can I expect as like the first couple sessions? Because in my experience, OCD therapy was like I explained my obsessions to my therapist, and then it was exposure.
Right. Yeah. Well, I mean, the first we do is some psychoeducation on a model, but we move pretty quickly forward towards one of the first steps, which is sort of an introduction where we highlight differences between normal and obsessional doubt, like I said before. Then we try to identify reasons why behind the doubt. We try to identify the obsessional sequence, which is very important. That's all at the start of therapy. Obsessional sequences in I-CBT is you have a trigger, like seeing a doorknob. We'll stay with the doorknob example. Then you have a doubt, or a primary inference of doubt. Maybe I did not lock it correctly. Then you have the secondary inferences. The consequences, it's sort of like an if-then format. If I left the door unlocked, then maybe, it can be anything. Maybe my house will be robbed. Maybe somebody will break in and kill my family, whatever that is. And then you have the anxiety, you have the compulsions. So identifying that is very important because it sort of like slows the OCD down a little bit, right? That's the first step that we start with. From there, we move on to the identification of the obsessional narrative, where we combine all these reasons into a narrative, because usually it takes the form of a story. OCD is pretty dynamic in a sense. It builds up in a seemingly logical way up to the doubt. It infuses, this whole story infuses the doubt with credibility and with power and with intensity. As we all know, that obsessions are extremely intense events, right? Where do you get that intensity from? Not so much the appraisal and its aftermath, according to I-CBT, but from this infusion of the narrative, this big story behind it as to why.
Yeah.
Also part of that is like, why do you create these narratives in the first place? Which is the vulnerable self-theme.
Is there an element of exposure kind of in the model as you conceive it? Or is this like, or ERP can be worked in by like an individual clinician, but like in its purest form, I-CBT doesn't have exposure. But
no,
what's
our trials, our RCTs do not include formal exposure with I-CBT. That's not to say that the argument cannot be made that there's an exposure element at the end of I-CBT in terms of where we ask people to go into situations after the cognitive work, and we ask them to go into situations where without doing things without putting any additional effort, right? So, but no, there's no intent or to do formal deliberate exposure and response prevention. Well, response prevention maybe, if you want to call it that, but to do any deliberate exposure in I-CBT. So in that sense, one of our hypotheses is what we're looking at is that maybe a little bit more of a tolerable treatment, a more acceptable treatment, easier to do for people. But that's not to say that you cannot combine, a clinician cannot combine ERP with I-CBT, but it cannot be done with the rationale of tolerating uncertainty because the models would clash. But I don't think it has to be part of that either.
You're right. It doesn't sound like it has to be, but it is learning about something, right? It sounds like learning to trust your senses. That's what the goal of the exposure.
Yeah, trust your senses. Exactly. Yeah. Ultimately, it's this building of self-trust and trusting your senses. Not going beyond reality, not going beyond the senses, and staying with your senses from the viewpoint that the senses give you all the information that you already need. You don't need more. You don't need to go beyond what you already know. Yeah.
So there's a question at 12:41, and I'm going to get to the questions at 45 if anyone's wondering why I haven't asked any questions yet. Michelle asks, so in I-CBT, are you reasoning your way out of OCD? And yeah, I guess, how would you respond to a question like that?
Well, I mean, it's a good point. I mean, with any sort of intervention, you have to be careful that the intervention does not become obsessional, right, or compulsive, right? So we see the same problem sometimes in ERP where a person compulsively starts exposing themselves, which is really like self-testing. It's actually the opposite of exposure when you do that, right? And in the same way, I-CBT would discourage trying to ruminate your way out of OCD, or analyze your way out of OCD, which has the opposite effect. So it's a general risk of any treatment intervention, I think, that people with OCD are vulnerable to, because the drive or the fear can be so strong that they do anything and everything to escape the obsession, right? And so, but that's not what I-CBT does. It works through the realization. It's not like when we explore alternative narratives that we pit one against the other. It's about a realization of the power of the imagination to begin with. And when we work on alternative narratives, we try to have them do it in a non-obsessional way. Narrative that's actually based in the senses, not putting one against the other.
Okay, so that is something that you have to be careful of in I-CBT. There's attention paid to making sure that the person isn't using that in a ritual.
Yeah, I think it applies to any treatment. I mean, when you tell a person don't suppress your thought, and the person may start obsessing about not suppressing their thoughts, right? Yeah. So you have to be careful in that sense, but you have to point out the process. You point out the same process. It's always the same process. So
Boy,
OCD can get very layered, right? One obsession on top of another, one on top. You have to point out it's really all the same thing. The process is all.
It seems like in I-CBT it would just be harder. It would be easier for someone to hijack that and turn it into, oh, my therapist said, or even, we did an exercise, and then to tell me that I can think this way, and then kind of use that as a ritual. But if therapists are careful about that and can,
you have to be careful about it. It's something that can happen, like in any other treatment, but it's not something that we see particularly. That is particularly something that I-CBT is vulnerable for. It's about focusing on the process. And educating people on the process. It's not about arguing with the OCD.
Got it.
Kelvin, do you have anything to add? Sorry, I haven't had too much time.
No. That's okay. And I'm not sure if Fred managed to get to it either, but I think he was leading to it at that a very important part of I-CBT as well is uncovering that vulnerable self-theme. So, before it was asked, like, why do people have, why do particularly pregnant women have particular thoughts around their children or, about being a bad mother or things like that. And I think a big part of I-CBT is about uncovering those self-themes. So ultimately, why is the obsession so contrast or ego dystonic, right? And it's because of this concept that we call the feared self that forms part of the narrative. And that's also very important, as Fred will describe in the therapy, to help them sort of uncover that as well.
Yeah. So you've done a lot of work on that. What can you teach us about kind of this feared self, and how does that develop? And is that specific to OCD?
I think at the moment how it was investigated initially was in OCD, as Fred, I think, or correct me if I'm wrong, Fred, 2003, the paper in 2003 or 2008.
Right. Yeah.
It's getting mixed up. And work building off some of like earlier work, self-discrepancy theory, Ferry and Bruin, like first terms, like the term feared self, but building on that, that work.
With us,
into OCD. I think the jury's still out probably whether or not it's unique, particularly to OCD, but at least the research right now shows that it is a causal factor in OCD, as well as changes in how people rate their feared self, changes across over time, over therapy, and it predicts better outcome in therapy.
Where does a feared self, like, how come some of us are afraid, have that feared self, or do we all have that? Help me understand, or help all of folks tuning in understand where does that come from?
I think there's and that's the sort of like the exciting stuff at the moment that sort of we're theorizing around, and this combines some of the work from Mike Kyrgios, who's also in Australia, as well as some other thinking around, how does the concept of the self develop in the first place? And one of in our discussions with me and Fred, there are these sort of critical periods potentially of self-identity development. So, adolescence, or it could be any other time, even during pregnancy, could be following a trauma. Any time really shakes up that core concept of asking yourself, well, who am I as a person? Right. We suggest that there, could be disruptions that occur during this period. What these disruptions are, where, again, trying to investigate this at the moment. But what that leads ultimately to is the person develops sort of a vulnerable self, like they're not entirely sure about who they are as a person. That leads them more vulnerable to developing this feared self-identity. Well, I'm not sure who I am. I could be blah. And this is in combination with some of those sort of reasoning processes that Fred describes and Fred highlights in I-CBT. So a combination of that sort of disruption in self-identity development during critical periods, and sort of these reasoning processes combined together to lead one to develop a feared self. That, they believe that, I could be this violent person, this terrible person.
Mm-hmm.
It also ties in a little bit with the concept of core fears, right? Even in an ERP model as originally proposed by FOA. So there are areas of overlap, but yeah, I think these disruptions, it's interesting. The age where OCD tends to develop is usually where identity and disruptions and identity are most likely to occur. What is the average age, Kelvin?
Yeah, so the average age of onset for OCD is around like 19, and that's during that period is that period of self-identity development. We actually showed in a fun experiment. If you were a fun experiment, fun for me, that actually, when we manipulate people to sort of healthy, non-OCD individuals, we manipulate them to develop a feared self.
Yeah.
Through our experiments, we show that people most vulnerable to this manipulation are those roughly around 18 to 19, as opposed to if they were older, the manipulation would have less of an effect in leading to an increase of a feared self. So that was actually also quite interesting and validating for this particular theory.
And the relevance of the feared self to treatment, can you go over that again?
So I'll leave that one I'll pass on to Fred with the I-CBT.
Okay.
Yeah, so we identified a vulnerable self-theme, and I think it goes back to the self-trust, right? Where we try to bring people back to their authentic self, because the feared self is a false self. It's not a real self. It's something we fear we might be, but not something we really are. So it's attached to us, but it's not who we are. And especially because we care about it. And OCD likes to hit us where it hurts.
Mm-hmm.
That's where obsessions go, right? So by learning self-trust again and realizing that the feared self is ultimately an illusion, you try to take away that vulnerability.
And okay, and that's different. I mean, you're going to say that's different from intolerance, from learning how to tolerate uncertainty. Like, this is just an illusion. See it as an illusion.
Because I understand your argument. You're saying it's easier to tolerate uncertainty when you trust yourself, right? That's sort of what you're saying.
Yeah, exactly.
Right? Yeah. But I think the point here is that there's no need to tolerate things that are not relevant to the here and now to start with.
And how do you know if something's relevant to the here and now? I mean,
that's the whole point, right? Is that doubt relevant to the here and now in terms of, is it based in any direct sense information that provides evidence for the doubt? And then we go back to what is a normal doubt, what is an obsessional doubt.
And so a person with OCD who has, let's go again with pedophilia thoughts, and then they have a sense like they get a groin response, for example, right?
Yeah.
So
that's a consequence of fearing being that person, and that often the consequences, OCD likes to use consequences as evidence for itself. OCD tends to create evidence that it then uses as evidence for itself, which is not a valid way of reasoning, because it's a circular type of reasoning. It's a consequence of fearing in the first place that you might be a pedophile that produces those sensations. You cannot use that then again as evidence for being a pedophile. It's circular.
So you're able to get patients to see that clearly and to not doubt.
It's interesting. I'm not going to say I-CBT provides an alternative. It's not necessarily more effective. That's not what we find in our trials. It may have certain benefits, I think.
Just to be what do the trials show? Is it more effective for particular populations? How does it compare to CBT?
Wait, before we get to that, because that is an important topic, but it seems to me like that groin response, like, is it a sexual response? Is it just normal? Is it anxiety? Right? I mean, there's no way for the person to know that for sure, and it doesn't seem, I mean, and exposure doesn't make them know that for sure. And, you know, it just seems like that's just something that we have to just kind of, we move on from. We don't try to figure out what it means. You can call that tolerance of uncertainty or not. I get it.
I call it irrelevant information.
But yeah, right.
It's not irrelevant.
But for a person with OCD, that sure as heck isn't irrelevant. That's to them, they see that as evidence that they're a pedophile.
Right, but it's not. You know?
Well, of course it's not. But try to tell an OCD person that.
Yeah, well, yeah, but I mean, so you're saying the obsession is wrong. So you agree with the fact that they don't have to tolerate being a pedophile or possibly being one.
Let's tolerate the uncertainty, is what Jon's saying.
Yeah, I mean, if I could just tell my patients, hey, look, that's, you know, when you get anxious, you have that groin response too. And there's no other evidence that you're a pedophile. So you can just move on and just discount that groin response. I mean, that would be like remarkable. But
it's just a consequence. It's just a consequence. It arises because of the doubt and fear to start with. It's the consequence. It's not evidence for anything. You have to go back to the lack of justification in the here and now and in the senses and in reality for the obsession to start with.
Okay, I see. So there's a whole process getting up to
exactly.
Yeah.
Okay, I hear you. Let's talk about the data.
Yeah, let's talk about the data. What's the efficacy for this type of treatment?
Yeah, so we did several trials. Several trials have been carried out, randomized control trials. It is as effective as ERP. It is as effective as appraisal-based CBT, so cognitive therapy combined with ERP.
So with no exposure involved.
Oh yeah, but we already know that for 40 years that cognitive therapy works as well as my former supervisor, Paul Hamilton, like you did in your setting your introduction, did the first study on that. They used the rational emotive therapy.
Well, but if you look at the studies that were done, those were not well done with all.
No, I agree with that.
Yeah, those were not.
I won't deny that, but there was already early evidence that cognitive therapies seem to work pretty well, and they. Anyways, that's not the point. I-CBT doesn't have exposure, and it works as well without formal and deliberate ERP.
Is that only for particular populations or just any type of OCD? Because I read
any type of these are any type of OCD. Yeah.
And there is an element of exposure we were talking about before, right? These sensing, experiences where we're helping people to kind of practice kind of trusting.
Yeah, of course. It's not about setting up a strawman argument saying there's no behavioral element in I-CBT, right?
Yeah,
I'm
right.
not going to make it. Yeah,
of
course, yeah. Well, I mean, but that's not formal and deliberate nor prolonged exposure, right? So
no, but they're engaging with the
for sure. There is a behavioral element after the cognitive work is done, but not with the purpose of producing anxiety, not with the purpose of tolerating uncertainty, not with the purpose of tolerating the stress. All those elements, the rationale is different, right? So yes, there are behavior is involved, but the rationale behind it is different.
Yeah, that's okay. Then that's what was really clear from reading the literature. Is that it sounds like technically there are a fair number of overlaps. It's not completely obviously it's not completely overlapping. There are some differences, but from theoretically, conceptually, it seems like there's some big differences.
Yeah, we did a whole. Actually, if you look at our last trial, it's actually we made it open access. We did a supplementary online material with it where we compare all the treatments and how they differ how they are similar in techniques, how they are different. Which has been done in a balanced way because we had also researchers from different models, authors, co-authors, and we looked at it carefully. What is similar? What is different? So if anybody's interested in that, what is similar and different? What are the overlap? What is not? I would suggest people have a look at that trial, and it's freely available, published in the Journal of Psychotherapy and Psychosomatics.
Yeah, I enjoyed reading that study. I wanted to ask you before we wrap up about mindfulness, with was that a control stuff?
It was sort of like a non-specific type of therapy, right, for OCD. So it was a control condition, which did pretty well as well.
So that was my question. The control condition did as well as the two active conditions. What do you make of that?
Well, it means mindfulness that are. I think we have to admit there are similarities and overlaps in all of these treatments, and I think it's a good thing for people with OCD. That means they have another alternative that is now, because this was the first study, we didn't not expect it, but this is actually the first study that we have in an RCT where mindfulness worked as well as either I-CBT or ERP or appraisal-based therapy, whatever you want to call it, which is great for people with OCD. That means it's an evidence-based, valid alternative. And we need an alternative. So it's not about putting one against the other, but providing people with alternatives and choices.
Yeah. All right. So yeah, a couple of points I just want to bring up. One is, that it's not about saying, we got this camp, and they're all different. I think, in terms of clinical work and in terms of helping folks who have OCD, we do best when we're able to kind of see the similarities and borrow from these different perspectives, whether it's ERP or I-CBT or ACT or what have you. But my other point, I liked, I enjoyed reading the paper in Psychotherapy and Psychosomatics. You guys pointed out the influence of non-specific factors in therapy that might account for why a treatment like mindfulness, which mindfulness on its own, of course, we wouldn't use that for OCD, but you do have non-specific factors that could account for improvement. When people expect to get better, they're getting attention, things like that.
Right. Yeah. That's sort of like the similarity across all treatments, right?
Exactly.
I mean, it's obviously it's not psychoanalysis either, right? We are all part of the CBT community, and I think there are certain principles we all agree on, right? So in that sense, there is no need for different camps in that way. So but yeah, I mean, we have to recognize, I think it's useful to have differences, and it's useful to discuss and debate in order to improve outcomes, and also and Jon, you always have been a proponent of that as editor as well, to give people with different views and different theoretical backgrounds a voice, also in your work as an editor. So I've always appreciated that. So it's not about that. It's about involving treatments and providing people with alternatives and better outcomes.
We're out of
time. Kelvin, you had one kind of closing comment?
I was just going to say, like, theoretically, even though these different theories might differ and their treatments might, that come out from might differ, I think importantly, it's, with our clients, it's what gels with them the most as well. Like theoretically, this makes sense to this patient, you might get more buy-in, and then you have those sort of that could be a non-specific factor that might lead to better treatment outcomes. So we're not working against each other.
And I do think that, this is not about this camp versus that camp and all of that. It's how do we work together? There might be different approaches that are helpful for different folks. I think
exactly. And clinically, there's also no reason not to. I mean, a lot about this is research debate and theoretical debate as well. But clinically speaking, there's nothing against combining different approaches. I think if it helps your clients and you have that judgment, clinical judgment, and say, okay, this could really work for you. Some mindfulness with I-CBT or some ACT with ERP, who knows? That's all fine clinically speaking, I think.
And it's a lot of fun to have good spirited academic debates. Like this is very intellectually stimulating.
This is by far my favorite one. I'm sorry to everyone in the chat who asked questions. There were a lot of really great questions. Things got pretty intense.
We'll have to do it again.
I learned a lot. This was really cool.
Yeah, we have all the questions, and we'll send them over to experts. We'll try to get them answered for you. And I would bet that there's probably going to be a second part to a discussion on I-CBT, because I feel like there's a lot we still have left to talk about. But thank you all for tuning in. Before we leave, I just want to say this live stream is one of many. You can see the entire schedule of future streams on icdf.org/peace of mind. And you can also watch all the previous live streams on the ICDS YouTube channel. Thank you, Fred and Kelvin and Jon. This was
Thanks for having us.
This is great.
Thanks.
This is great.
All right, great. Thank you.
Thank you.